Free.
All right. Morning again. Still Dr. Shandu, delivering a talk about HIV and skin. Yes. So, okay, good. Yeah, this is what we're going to be talking about today: epidemiology of HIV in South Africa, including the skin lesions, with relevance to HIV in South Africa. We're going to look at some of the common types of skin lesions, classification of skin pathologies in HIV, and we're going to be seeing quite a whole lot of pictures with examples of skin pathologies in HIV. So our learning objectives for today would be, after this presentation, we should be able to define a lesion, diagnose a pathology, we should be able to treat those pathologies, and if ever you hit a rock or a very hard place, don't forget, consult or refer. Right, so some of the statistics of, or rather on HIV in South Africa. So approximately 13.7% of the South African population is known to be infected with HIV. That's about 8.2 million people who are affected by HIV in South Africa. These stats are of 2021 rather. So for individuals between 15 and 49 years, an estimated 19.5% of the population is HIV positive. In 2021, again, 198,000 new HIV infections were recorded in South Africa. And of those, 85,154 died or succumbed due to AIDS-related illnesses. All right, so yeah, the importance of HIV skin conditions. So they're quite common. It's about 36 to 52% of people who have HIV manifest these skin conditions. The prevalence rate in South Africa, sorry, that should be South Africa, is 85%. So we have 37% of people who present with these skin lesion conditions as a marker of HIV, which is how we get to diagnose HIV. We first see the skin lesions and then we investigate further. So 90% will develop skin problems during HIV. And a CD4 count, when a CD4 count decreases, this increases the severity of the skin lesions. So with the use of ARV therapy or ARVs, the incidence of some of these skin disorders has declined, but the incidence of drug reactions and non-infectious skin eruptions has increased. We are going to see this when we go through the classification. A variety of neoplastic, infectious, and non-infectious diseases produce cutaneous manifestations throughout the course of HIV disease. Also, we will see this when we go through the classification. So most conditions occur when most conditions occur more frequently in persons without HIV infections, but are more severe with those that are infected with HIV. Cutaneous disorders may result from HIV infection itself or from opportunistic disorders or diseases secondary to poor immune system. So it may be initial signs of HIV-related immunosuppression. So we're going to go through some of the groups that are mostly affected by HIV in South Africa. We have the MSMs, so those are men who have sex with other men. We have women and adolescent girls, people who inject drugs, excuse me, sex workers and migrant workers, such as truck drivers and people who just move around. So these are the important aspects in assessing a skin lesion. So you should, if you're defining a skin lesion, you should tell us about the size, the pattern, elevation, is it elevated or not? The color, is it erythematous, or is it just a hyper discoloration, or hypo location of the lesion, the shape, consistency, and the borders. This is some of the patterns of the distribution of the lesions on the body. So we're going to go through, some common types of lesions, and we're going to see all these as we go through. So we have lesions like vesicles. These are small fluid-filled sac of less than 0.5 centimeters in diameter. Nodules, a large, solid, palpable, and or elevated area, which is larger than 0.5 centimeter in diameter. Plaque would be a lesion slightly raised over a large area. We have crusts and scales. So crusts are yellowish extension of a surface of a lesion, and scaling or scales is a disease stratum corneum. So it's visible. You actually can see a skin looking like scales. I'm not sure if you can clearly see there. It sort of like breaks, but it's not really deep. It's quite. We have erosion, which is a lesion with the loss of surface or surface epithelium. And there's peeling of the skin, where there's damaged skin that is being shed, as we see it on the screen. Right, we have bull eyes, which are large blisters that are filled with clear fluid and more than 0.5 centimeters in diameter. Macules are a flat, distinct, discolored area of the skin. So it usually does not include a change in skin texture or thickness. We have papules, which it's an elevation. It's a solid elevation, palpable lesion that is less than or equal to 0.5 centimeter in diameter. And they may be solitary or multiple. You have pustules, which are more or less the same. The definition is the same as a papule, but this one is filled with pus. Skin ulcers as well. So a lesion with loss of surface epithelium and deeper tissue. The skin ulcers can be caused by a prolonged period of poor blood flow to an area of the body. We're going to correlate some of the diseases we're going to go through with the CD4 count. So we would have a CD4 count of over 500. This is where we would most likely see diseases like psoriasis and seborrheic dermatitis. So for the CD4 count that is between 200 and 400, we would expect to see something like candidiasis, dermatophytes. Dermatophytes are tinnias, so the tinea infections, condylomas, varicella zoster, papular eruptions, herpes simplex, and eczema. With the CD4 count that is less than 200, we would expect to see herpes simplex virus that is more than 1 month. So it's a chronic herpes simplex. Kaposi sarcomas, histoplasmosis, cytomegaloviruses, PPEs, eosinophilic folliculitis, cryptococcosis, and Mouscum contagiosum. All right, so with relation to the WHO clinical staging for HIV and AIDS, we have put some of the skin lesions according to the stage that they belong to. So in stage 1, we don't really see much of these skin lesions. On stage 2, we would have PPE, fungal nail infections, extensive warts, virus infections, extensive molluscum contagiosum, herpes zoster, and seborrheic dermatitis. There's not much involvement in stage 3 as well. So stage 4, we would have chronic herpes simplex, which is an infection that is more than a month. Extrapulmonary TB, which would be TB skin in our presentation. Extrapulmonary cryptococcosis, disseminated mycosis, and Kaposi sarcoma. Right, so there are a lot of ways of classifying these skin pathologies, but this is the one that I chose. So I'll classify them into infective and non-infective, if you may. So under the non-infective, we have the inflammatories, which are eosinophilic folliculitis, psoriasis, seborrheic dermatitis, PPE, and atopic dermatitis. We would have neoplastics as well, which are Kaposi sarcoma, non-Hodgkin lymphomas, squamous cell carcinoma, and drug reactions. Under the infectives, we would have bacterial, which would be impetigo, TB skin, and furuncles. And the fungal would have tinea, candidiasis, and cryptococcosis. Under the parasitic, we would have scabies. Under the viral, we would have herpes zoster, herpes simplex, HPV, and molluscum contagiosum. We'll be going through these examples and seeing how they look like. We'll start with the non-infectious ones. So under the inflammatory ones, so this is seborrheic dermatitis. It's a common skin condition that mainly affects your scalp. It causes scaly patches, red skin, and stubborn dandruff. So for the general management, we just have to trim our nails, as that would be a medium of spreading. Avoid scratching, avoid perfumed soaps. And on our pharmacological management, we use hydrocortisone 1% topical cream. We apply it 2 times a day until there's improvement, and then 2 times a week for maintenance. Next one would be psoriasis. So it's a skin disease that causes a rash with itchy, scaly patches, most commonly on the knees, elbows, trunk, and scalp. It occurs when skin cells are replaced more quickly than usual. So it's not known exactly why this happens, but research suggests it's caused by a problem with the immune system. The general management would be encouraging sun exposure as tolerated, and counseling regarding precipitating factors and chronicity. So in this case, it would be the HIV virus. Under the pharmacological management, we use coal tar BP, which is 5% topical cream, and steroid betamethasone 0.1% topical cream 12 hours. Eosinophilic folliculitis. This is an inflammatory reaction secondary to unknown triggers. So it's erythematous, papules, and pustules. Mostly affects the face about 85% of the time. So back and extensor surface of upper extremities as well. So the management would be using your ARVs, of course, and your topical steroids again, twice a day. So the PPE. So this develops in 10 to 45% of patients with HIV and is a sign of immunosuppression occurring at a CD4 count of less than 100 or 200. The cause is not really known. So you get these itchy papules mostly found on the trunk, and it's a stage 2 defining condition, like we saw it on the classification. The diagnosis is clinical. You always have to exclude other causes, so e.g. your scabies, and it's usually very resistant to treatment. So that's one way of seeing what we're dealing with. Treat with potent topical steroids and oral antihistaminics. So betamethasone 0.1% twice a day, cetirizine 10 milligrams per ounce daily. And we keep our nails short as scratching can cause secondary infection. All right, so we're going to move to drug reactions or skin lesions caused by drugs. So they all need referral. And the drugs that we commonly use in our setting would be the ARVs, the Bactrim, and the TB drugs. So with the use of ARVs, the incidence of some of these skin disorders has declined, but the incidence of drug reactions and other manifestation, non-infectious skin eruptions have been enhanced. So these are some of the lesions we might see with some of the drugs that we use. So with AZT, we might see hyperpigmentation, vasculitis, pyronychia. Abacava would be maculopapular pleuritic eruption, urticaria, erythema multiforme. So 3TC, allergic contact dermatitis, and pyronychia as well. FTC would be hyperpigmentation as well, solely of the palms and soles, and hypersensitivity reaction. For nevirapine, we would see your Stevens-Johnson syndrome, which is an important one there, acute generalized exothermous pustulosis. With the efavirenz, it would be, your mild skin eruption and vasculitis. Right, so this is a presentation of your Stevens-Johnson syndrome. Yeah, we can just go through those pictures later on the slide. This is how you'd see your toxic epidermal necrolysis, which is one of the drug-induced reactions. So let's go through to our neoplasms. Kaposi sarcoma. So it is a type of a cancer that forms in the lining of blood and lymph vessels. 15% of the people with AIDS show this type of skin lesion. It is linked with human herpes 8 virus. So the skin has these purple looking patches or plaques and nodules. They're related to reactive skin thickening. The management would be ARVs, of course. And if it depends on how much it has spread. I mean, if the spread is too much, then we go through a palliative management, which would be radiotherapy and chemotherapy. Right. So under our infectious now, we have folliculitis, eczema, and furuncles together. They are bacterial infections, localized bacterial infections caused by normally Staphylococcus aureus. So folliculitis would be papules and pustules which may be excoriated. So it is an infection of the hair follicle. That's why it's called folliculitis. Eczema, ulcers on buttocks and lower limbs. Furuncles are soft, painful, erythematous nodules. The management would be treating with antibiotics and continuing with your ARVs. Topical cream is also used for the localized lesions. And extensive lesions, we use topical flucloxacin. Still under bacteria, we have impetigo. So it's a common contagious skin infection caused by streptococci and staphylococcus. It's predominantly found in children. The management would be povidone iodine 5%, cream or, cream there, shouldn't be a comma there, or 10% ointment. So you apply 8 hourly. Fluoxacillin, oral 500 milligrams 6 hourly for 5 days, or we can use azithromycin orally 500 milligrams for 3 days in case of penicillin allergy. We also have skin TB. So the lesions are firm. They are normally painless, slow-growing nodules and papules. Ulcers may also develop in this lesion, and these lesions may resemble those of lupus vulgaris or scrophulodema. So the management is we just manage using TB management. So your Rifafor, Urifin. Right, moving on to viral infections. Herpes simplex, right. So a virus causing contagious sores, most often around the mouth, that would be type A, or rather type 1, sorry, or on the genitals, which would be type 2. So it's a stage 4 defining condition. This is when it is chronic, as we've explained before. So in HIV with herpes simplex virus, the recurrent lesions become more severe. It is mainly transmitted during sex through contact and with genital or anal surfaces, skin, sores, or fluids, or some infected with the virus. So with the general management, we just keep the skin lesions clean and dry. And for the pharmacological management, we use acyclovir 400 milligrams per os 8 hourly for 7 days. Herpes zoster. So it's a reaction of a chickenpox virus in the body, causing a painful rash. So it causes a painful rash that may appear as a strip or blister on the torso. The pain can persist even after the rash is gone. So this is called post-herpetic neuralgia. So a chickenpox vaccine is in childhood, or shingles vaccine as an adult can minimize the risk of developing shingles. The management, we use acyclovir 800 milligrams per os 5 times a day for 7 days. If the secondary infection, we use fluoxacillin 500 milligrams per os 6 hourly for 5 days. And for the pain management, we use paracetamol 1 gram per os 6 hourly, or tramadol 500 milligrams per os 8 hourly. Amitriptyline 25 milligrams per os nocturne for pain after the shingles have resolved. So this would be for the pain we spoke about, pain that comes after the disease has resolved. Okay, so one of the signs we have to look out for in herpes zoster would be the Hutchinson's sign, which is its vesicles presenting in the tip of or the side of the nose. So it reflects zoster involvement of the first branch of the trigeminal nerve and is concerning for the herpes zoster of Dunn-Mucus. So it may cause blindness. HPVs. So it's an infection that causes warts in various parts of the body, depending on the strain. There's no cure for the virus, and the warts may go away on their own. So treatment focuses on removing the warts. The management would be, in most cases, they resolve on their own, like we've said before, but if not, we use salicylic acid, 15 to 30% topical liquid application. So what you should know is that when you use this, you should protect the surrounding skin. We normally use petroleum jelly so that it doesn't burn the whole skin. If this doesn't work, we use cryotherapy, electrocautery, and curettage. Right. Molluscum contagiosum. It's a viral skin infection that results in round, firm, painless bumps with a depression at the center. General management would be allow lesions to heal spontaneously, and the pharmacological management would be we use something called a tincture of iodine BP. So you apply to the core of individual lesions using an applicator. So as we see, these lesions have these depressions. So you just apply on the core of the lesion, around the lesion. And we should be very aware of iodine sensitivity with the use of the iodine BP. Right. Let's move to fungal infections. Candidiasis. This is a skin infection that is caused by a fungi called Candida albicans. It commonly affects skin folds like groins, axilla, and nail folds. We mostly see it under the breast as well. The pharmacological management would be clotrimazole 1% cream. You apply it 3 times a day for 14 days. We will also see tinea, so tinea corporis, which might be a differential for candidiasis. So one way of differentiating is if you look at that lesion, you see the borders are not really quite as defined as we'll see on teneas, and they do have what we call satellite lesions. So those lesions that are around the very main lesion. So yeah, like I said, this is a tinea corporis. It's itchy ring-like patches with raised borders that are caused by dermatophytes. So as the patches extend, a clear hyperpigmented center develops, as you see on the picture at the top. So the general management is we do not share clothes, we do not share towels or toiletries, especially combs and hairbrushes, to avoid spread of the disease. You wash and dry skin well before applying medication. And for the pharmacological management, we use clotrimazole cream, 1%. We apply it 3 times a day. So continue using the cream for at least 2 weeks after the lesions have cleared. Tinea capitis. So these are patchy, bald areas on the scalp with scales and stumps of broken hair. So they're also caused by dermatophytes. General management: do not share combs, do not share brushes, avoid shaving the head as this may spread the fungi. Pharmacological management: fluconazole 200 milligrams per oz weekly for 6 weeks. So this is not to be used by women of childbearing age unless on effective contraception. Tinea vesicolor. So these are circular macules that are usually hypopigmented, but they can also be hyperpigmented. As we can see in the pictures, we have both. They are caused by Malassezia furfur, mostly found on the upper chest and the back, and the distribution is often central and it spreads towards the laterals. Pigmentation may take months to return to normal after treatment. So they're normally recurrent, especially in hot weathers. So this is what we normally refer to as tin stuff. The general management is to avoid heavy clothing during the hot weathers. Pharmacological management would be, okay. So Dr. Miller just helped me and told me that we normally use ketoconazole in our setting. So ketoconazole shampoo. I don't think we have in our setting, but usually you can ask the patients to buy ketoconazole shampoo at the pharmacy, and then you can apply over a very large area.
we'll only have clotrimazole, but that won't work quite as well because you have to apply large amounts regularly for a long time. But yes, in private, it's ketoconazole shampoo.
Okay. All right, so okay, we have scabies. We're now on the parasites. So scabies is caused by mites or Sarcoptes scabiei. So they spread by close personal contact and burrow into the skin. These lesions are intensely pruritic papules, and yeah, they're very, very pruritic. And they normally, the extension is usually found in the wrist flexors, in the web spaces, in the ulnar surface, in ear, in early stages rather. Trusted lesions on the atypical site of the face, but we normally see these lesions on the hands and the feet. So, those, the web spaces of the hands and the feet. And then we do also see them on the face. In HIV, scabies tends to recur despite adequate treatment. It's one of those very stubborn pathologies to deal with. Yeah, and they also affect quite a number, like most people of the household. So when you treat, you should treat the whole household rather than just treating the person who exhibited symptoms. So for the general management, like I said, treat all close contacts simultaneously despite presence of symptoms. It's the washing of clothes in hot water, exposing all bedding in direct sunlight, wear clean clothes after applying medications. Well, for the pharmacological would be applying the benzoyl benzoate 25% topical cream all over the body except for the head and the face. So you wash the cream after 24 hours. This may be repeated after 24 hours or within 5 days for severe infestation. So you do this, and for the person who is infected, you repeat this management after 7 days. So after 1 week, you repeat the management for the one that's infected or the one that shows symptoms. For the rest of the family, they can just do this once. Still under parasitic, we have leishmaniasis. It's an infection with leishmania parasites that spreads by that are spread by sandflies. So the most common forms are cutaneous leishmaniasis, which causes skin ulcers. The management we normally does not require treatment, but a use of amphotericin B has been proven to be useful. So for the take-home message, we should know how to define a lesion. We do not forget to examine the skin and expose the patient as needed. Suspect more severe conditions in patients with lower CD4 counts. Know what common conditions occur and how to treat them. And there are many skin lesions that are associated with HIV. If ever you find yourself stuck, do not hesitate to consult or refer the patient. Yeah, that would be it.
Thank you very much, everybody. Thank you very much for those people who stayed on the call and managed to not see our lovely pictures, but we are going to be sending around a the recording of this presentation, which is much better with all the beautiful pictures that Dr. Shandu has added. So thank you very much to Dr. Shandu who's organized this. I want to just add two last things, and then we can open it for discussion. I think the first thing which Dr. Shandu ended up with there is that I think there's more than 4,000 different rashes out there. And I used to work with a dermatologist that used to say every patient deserves a diagnosis. So I think it's worthwhile when you're out there, and especially with the current possibility of WhatsApp and telemedicine, is that do not just go for the, oh, I'll just treat it blind. I have no idea what this is, but let's just throw something at it. If you're not sure, take some pictures and, find your sort of local doctors that loves a bit of derm. I'm one of them. Send a picture, a little bit of a history, and let's see if we can help that patient. The more better your diagnosis is, the better you're going to be able to treat that patient. And then the second one is a very practical trip. So a lot of these conditions, especially in HIV, does not necessarily present just as one thing. So quite often they get super infected, most often by bacteria. So people might have PPE, but they scratch it and now they have a bacterial infection on top of it. Or seborrheic dermatitis is usually a yeast infection that's got bacterial infection on top of it, and that drives the infection. So quite often to clear the skin of bacteria is quite tricky. For most of our antibiotics don't have great skin penetration. So you sort of actually manage to kill off some of the bacteria, but quite often, especially Staph aureus, loves to live in moist areas. So it loves to live in skin folds. It loves to stay little colonies on the inside, just on the inside of your nostrils, and those colonies can persist. So sometimes you'll find people, you treat them for their boils or their furuncles or their impetigo or their seborrheic dermatitis, and then it just, as soon as the antibiotics is finished, it just flares up again. So the classic ways we normally clean the skin is either using potassium permanganate, the clinics know that quite well, or your betadine washes, but both of those are very messy, and we don't always have them necessarily on site. So a great tip that a dermatologist gave me, it was actually based on a study done by a dermatologist in America, is to use common bleach. So most patients have bleach at their homes, and the way you explain it is that the ratio is 10 mils of bleach, 15 mils of bleach, a tablespoon of bleach for every 10 liters of water. So you would say to the patient, and they're going to do bleach baths. So when they have a bath, they take, say, your normal bath is about 40 liters, or they, if they're using a hand bucket, of every 10 liters, every bucket of water, they add 1 tablespoon of bleach, sort of the normal common variety, not flavored kinds. It smells a bit like a swimming pool, and it's not a very strong concentration. So like a swimming pool, it doesn't make your clothes go white or bleaches your skin or anything like that. It's therefore, just like you can swim in a swimming pool. It's not you're going to burn your eyes or probably problematic with your hair. And you can therefore wash the whole body with that. And you can do that regularly. My own family does that every time we go through a phase with the horses where everybody starts getting all kinds of skin infections. It's a great way just to clean the skin. And that's very useful even for small bacterial infections. But even when you're treating somebody with flucloxacillin, that you add the bleach baths. Remember, if you're treating somebody with oral antibiotics for a skin lesion, to not also use a topical antibiotic. So you can't use fusilin cream on the skin and give an oral antibiotic. I think it actually encourages bacterial resistance for whatever reasons. So generally, you can use an antiseptic on the skin with an antibiotic, but not antibiotic and antibiotic. So that's my 2 top tips. And it's amazing how often I tell people to have bleach baths. It's extraordinary how many skin stuff we see that's got a bit of bacteria in it. So I would like to find out if anybody here in the family medicine boardroom has questions. For those that are still on the call with us, you can place your questions in the chat, and I'll have a look in a minute. If you do have a question or a comment, you need to come forward to the hot seat so we can actually record your voice. Just check if our chat here has anybody with questions. And then yes, says thank you very much for everybody on the Zoom that's adding their names, their MP numbers, and their email addresses for our attendance register. Please do that if you haven't yet done so. I don't see any specific questions or hands at the moment. Anything from the floor? I do want to apologize again for all our logistical issues. We have recorded this presentation, and I will put it on YouTube this weekend, and we will send down the link to everybody so that it will be available for future use. Thank you very much to Dr. Shandu for doing all the effort to put this great resource together. I think it's going to be used by many doctors in the future as well, to when they need to go and look up their skin lesions. Last, thank you from you.
Right. Thank you, everybody. Have a wonderful day.
And just a quick last thank you also to Dr. Yusimi, who's the power behind these presentations and who has spent many late hours helping Dr. Shandu put together this excellent presentation. So thank you very much, everybody, until our next meeting.